Hello everyone. Today I'll be briefly explaining about the pulpotomy and pulpectomy procedures and emphasizing mainly on the materials which are used in them. Okay. So pulpotomy is the complete removal of the coronal portion of the dental pulp, followed by placement of a suitable dressing or medicament that will promote healing and preserve the vitality of the tooth. Okay. Another definition says that it is surgical removal of the entire coronal pulp, which is presumed to be partially or totally inflamed and possibly infected, leaving behind the intact vital radicular pulp within the canals. Okay. The indications are the tooth has to be free of any kind of radical pulpitis, that is root pulpitis. Pain, if it is present, it should not be spontaneous or persistent. Teeth should be restorable, and the tooth should possess at least two-thirds of its root length, which is complete. There is no evidence of any kind of resorption, internal or external resorption. There is no interradicular bone loss, no abscess of fistula, and hemorrhage from the amputation site is pale red, easy to control. This is once we enter into the pulp chamber and remove the coronal pulp, the hemorrhage which happens should be easy to control. Okay, if it is sluggish or if it is purulent, then pulpotomy is not indicated. Then caries or mechanical exposure in a vital primary tooth. There are certain contraindications: root resorption exceeding more than one-third of the root length. If the hemorrhage at the radicular orifice, just now I told, if it is viscous or sluggish, then also it is contraindicated. If there is any kind of mobility in the tooth, total or partial necrotic radicular pulp, then on radiographic examination, if any of these radiographic findings are present, like if there is a large carious lesion with apparent pulp exposure, if there is interrupted or broken lamina dura, if there is widened periodontal ligament space or radiolucency at the root apices or in the furcation area, all these are the contraindications. In such situations, pulpotomy is not indicated. Okay. So just we'll have a look at the basic what the technique involves. Okay, so here we use a local anesthesia and put a rubber dam on the tooth, because traditionally the material which was used is formocrosol, and it is also one of the most common materials used till now, and formocrosol is caustic. Okay, so we need to put a rubber dam. So we use LA, put the rubber dam, then we use a number 4 or number 8 burr, okay, at a very slow speed to remove all the carious dentine which is there. If possible, you have to remove all the carious dentine before exposing the pulp one, okay, and then place number 330 burr in high speed to gain access into the pulp chamber. So once you get that dip and enter into the pulp chamber, then you have to remove the entire coronal pulp, that is a pulp which is present in the crown portion, and leave behind the remaining vital pulp in the radicular portion, that is the root portion. Okay, and then place a suitable dressing, that is any kind of material of choice. Okay, like for example in this picture, a formocrosol impregnated cotton pellet is placed, and then over that you place your permanent restoration. Here it is shown zinc phosphate. This was a traditional method in which ZOE followed by zinc phosphate and then stainless steel was placed. Okay, so nowadays there are a lot of advanced materials and techniques which can be used, but the basic procedure or the technique remains the same. Okay, medicament over that permanent restoration followed by a stainless steel crown. Okay. So broadly, the pulpotomy procedure is categorized into three treatment approaches. Okay, the first one is devitalization approach, the second is preservation approach, and the third one is regeneration approach. Okay, in devitalization, the material which is used is formocrosol. Okay, formocrosol, the main intention is of mummifying the radicular pulp tissue. Okay, then comes the preservation approach. In this, the main uh, purpose is minimal insult to the orifice tissue and to maintain the vitality and normal histologic appearance of the entire remaining radicular portion of the pulp. Okay, so that's why it's called preservation. And regeneration is the approach in which we use agents which have cell inductive capacity to either replace the lost cells or to induce existent cells to differentiate into hard tissue forming cells elements. Okay, so in revitalization, we used formicrosol. In preservation, we used pharmacotherapeutic agents like corticosteroids, zinc oxide eugenol, then glutaraldehyde 2%, ferric sulfate, and there are certain non-pharmacotherapeutic techniques like electrosurgery and lasers. Okay, and regeneration, we use calcium hydroxide. Okay. According to technique, it can be categorized into complete pulpotomy or partial pulpotomy. That is, partial pulpotomy is also called as Swick pulpotomy. So, complete is the complete removal of the pulp from the coronal portion, that is from the pulp chamber. And partial pulpotomy is where the inflamed pulp tissue beneath an exposure is removed to a depth of 1 to 3 mm or more to reach deeper healthy tissues. Okay, it is indicated for vital traumatically exposed young permanent teeth, especially where the root formation has not been completed. Okay, it is still incomplete. There it is mostly indicated. Now let's have a look at the pharmacotherapeutic agents. Okay, so the most popular ones are formicrosol, okay, then followed by glutaraldehyde, calcium hydroxide, ferric sulfate, MTA. Okay, there are non-pharmacologic ones which use hemostatic techniques, okay, electrosurgery, lasers. The traditional agents are these: formicrosol, calcium hydroxide, zinc oxide eugenol, and glutaraldehyde. Okay. The recent agents and techniques which are used include MTA, collagen, freeze-dried bone, bone morphogenic proteins, and electrosurgery, lasers. All these are the recent ones. Okay. Now let's have a look at the traditional, the most popular, the most commonly used one, that is formicrosol. Here Buckley's formicrosol is used, that is 3 parts of glycerin with 1 part of distilled water is mixed with 1 part of formicrosol, okay, and then we get a concentration of 1/5 concentration of formicrosol is thus made, and this is used during the procedure. Okay. And the mechanism of action is that the aldehyde group, because it has formaldehyde, that forms a bond with the side groups of the amino acids which are present in the bacteria and those which are present in the pulp tissue. Okay, so this converts bacteria into inert compounds and inactivates the oxidative enzymes which are present in the pulp tissue, and thus causes fixation of the pulp tissue. Okay, it renders it inert and resistant to enzymatic breakdown. Okay, so it has certain disadvantages, this formicrosol, but we are using it in a very low concentration. Okay, the estimated, this is a very important question which is asked sometimes, that how much is the dose of the formaldehyde or formicrosol which is used. So the formaldehyde dose in one pulpotomy procedure, where we are taking a 1:5 dilution of formicrosol, is placed on a number 4 cotton pellet, that is the size of the cotton pellet which is used. Okay, and then it is squeezed dry. Okay, squeezed dry until we get this. So you have to take just one small drop of it and then squeeze dry it. Okay, so we get a concentration of 0.02 to 0.1 milligram. So the mean dose which is usually used is 0.013 milligram per pellet, which is very low dose. Okay, the number 4 cotton pellet is of the size of 1/8 inches in diameter. So the disadvantage and concern with formicrosol is that it is carcinogenic. Okay, and it causes immune sensitization, mutagenicity, cytotoxicity. Okay, that is a major concern. Okay. The major concern is with formaldehyde. Formaldehyde, which is the main component of formicrosol, is the one which has all these disadvantages. Okay, it has been shown to be distributed systemically also after pulpotomy. So there's a lot of research which has been done on this. Okay, and there is now sufficient evidence which shows that formaldehyde can cause nasopharyngeal cancers in human. Okay, so that is a major disadvantage and concern which led to the introduction of other materials. Otherwise, this is still considered to be a gold standard in pulpotomy procedures. Okay, these are certain modifications like Guy's triopaste formula. The composition is written over here. So mainly it has, all these have mainly paraformaldehyde in their composition. Okay, Acelix paraformaldehyde formula, paraform devitalizing paste, all these render the pulp tissue inert and the bacteria also. Okay, so they have bactericidal effect, and thus these are used in the procedure. Then ZOE was introduced. ZOE is zinc oxide eugenol. It was introduced for preservation approach. Okay, it acts as an obtundant. It has a very soothing effect on the pulp, and the eugenol, it directly contacts a vital tissue, can cause mild inflammatory response. Nowadays, reinforced ZOE materials are also used like IRM, okay, and ZOE BNT, that contains polymethyl methacrylate, zinc oxide, acetic acid, and eugenol. So it has improved mechanical properties. Okay. Then glutaraldehyde, it has aliphatic dihaldehyde, is highly reactive compound. Usually it is stored in aqueous solution to inhibit polymerization. It was first used as pulpotomy agents in humans by Ranley and Lazare, okay, in 1978. It has a larger molecular size than that of formaldehyde, okay, because of the two functional groups. So this is the reason that it does not penetrate periapically or into the periradicular spaces, or does not enter uh, systemically. Okay, 2% of the solution is considered to be bactericidal, virucidal, and fungicidal. Okay, so it destroys all a wide range of microbes, and it is soluble in water, so it has a shelf life of around 1 year. So compared to formaldehyde, it has small molecular size, so it penetrates periapical and easily. It does not penetrate periapically. This fixes the tissues with a long reaction time and excess solution, while this fixes the tissue instantaneously. Okay, and excess solution is not needed, and also it is less cytotoxic compared to formaldehyde. Then comes ferric sulfate, another preservative agent used in the preservation approach. It is a non-aldehyde chemical. The main mechanism of action is that the ferric ions from the ferric sulfate, they form a ferric complex, and the membrane of this complex seals the cut blood vessels mechanically. And this produces a blood clot which occludes the capillary orifices. Okay. Then comes mineral trioxide aggregate. It is based on Portland cement as the major ingredient. After being mixed with water, it generates uh, in its unset stage a higher pH, which is similar to calcium hydroxide. So that can cause cell coagulation. That alkaline pH can cause cell coagulation. Okay, the composition of MTA is Portland cement, bismuth oxide, and gypsum. These are the three main components. So Portland cement includes tricalcium silicate, dicalcium silicate, tricalcium aluminate, tricalcium oxide, and tetracalcium aluminoferrite. Okay. The mechanism of action is calcium oxide from the calcium hydroxide with water. Then that calcium from the calcium oxide reacts with carbon dioxide from the pulp tissue and produces calcite crystals. A rich extracellular network of fibronectin as initial step is formed, initiating the formation of hard tissue barrier. So it forms a hard tissue barrier just like calcium hydroxide, but there's quite a lot of research which has been done on both the materials, and it has been shown that the barrier which is formed with MTA is much stronger and less porous compared to calcium hydroxide. Okay, calcium silicate hydrated gel is formed once it completely set. The mixing of MTA, it is always kept in containers with tight lids and away from moisture. Okay, it is usually mixed with sterile water or saline in a ratio of 3:1. So the properties are that it is hydrophilic. Okay, so even in a moist environment, it needs a moist environment to set basically, and setting time is long. Okay, that is one of the disadvantages. Setting time, it takes 2 hours 45 minutes around for the initial setting. Okay, then initial pH is 10.2, which rises up to 12 to 12.5 in 3 hours after mixing, and compressive strength immediately after setting is around 40 megapascal. After 21 days it increases to 70 megapascal. It's found to be non-mutagenic and less cytotoxic. So MTA, it has the ability to stimulate cytokine release from the bone, and that indicates that it is actively promoting hard tissue formation. Okay, so it is regenerative material, and MTA has antimicrobial properties which are similar to those of zinc oxide eugenol. It does not have any cytotoxic effect. Major disadvantage is that it needs a moist environment for setting for 6 hours. Okay, so setting time is quite long, and thus what normally is considered as a one-step procedure with MTA, or any medicament like this, it becomes a multiple visit procedure. So a two-step procedure with MTA, because wet cotton pellet needs to be placed, okay, over it until it is set completely, and then later permanent restoration can be fabricated over that. Okay. Another recently introduced material is propolis. Okay, it's a wax cum resin substance that is produced by bees. It is shown to have antibacterial, antiviral, antifungal, and immunostimulation and cytostatic activity, mainly due to the presence of flavonoids which are present, aromatic acids and esters. Okay. Then there is another one which is called Pulpotomy. It is a radiopaque non-resorbable paste which is available in powder liquid form. Okay, powder has polyoxymethylene and iodoform, and liquid has dexamethasone acetate, formaldehyde and phenol. Okay, it causes cicatrization of the pulpal stump at the chamber canal interface. Okay, scar formation. Then nanohydroxyapatite, it is a biocompatible material which is non-irritating to the pulp. Okay, the significant difference compared to the gold standard formocrosol is in terms of pulp response. Nanohydroxyapatite appears to be more biocompatible, and it provokes only mild inflammatory reaction in the pulp tissue. Okay. Then there is bioactive glass. It has 53% silica, 23% sodium oxide and calcium oxide and phosphates. Okay, forms a carbonate apatite layer. Localized areas of inflammation are seen in the pulp, in the mid-root portion, and it also has been shown to form an odontoblastic layer, which is formed usually around the 4th week. Then there's Ankerford blood stopper, that is a herbal extract which is obtained from 5 different plants. These are the names of the plants which are from which it is extracted. Okay, so studies have shown that it has a success rate ranging from almost 90 to 100%. Now let's have a look at pulpectomy. Okay, pulpectomy or pulp extirpation is a complete removal of the normal or the diseased pulp from the pulp cavity of the tooth. According to Engel, removal of the pulp or pulp extirpation is pulpectomy. Okay, another definition says that pulpectomy is extirpation of the vital pulp, normal or abnormal, followed by sterilization and filling of the root canal. Okay. The rationale here is to remove the irreversibly inflamed or necrotic radicular pulp tissue and gently clean the root canal system, to obturate the root canals with the filling material that will resorb at the same rate as the primary tooth and will be eliminated rapidly if it accidentally extrudes through the apex. Indications are pulpal inflammation extending beyond. So indication of pulpal inflammation extending beyond the coronal pulp, but with root and alveolar bone free of pathologic resorption. Okay, there should not be any internal or external resorption. Carious pulp exposure, in which following the coronal amputation the radicular portion exhibits clinical signs of hyperemia or if there is excessive hemorrhage which we cannot control. Okay, necrotic pulp, minimum root resorption and minimum bony destruction in the bifurcation area is also an indication. Non-vital primary teeth with sinus tract abscess are indications. Pulpless primary teeth without any permanent successors. When we need longer than normal retention of a primary tooth, then we need to do pulpectomy. Okay, traumatized primary incisors with resultant pathologic condition in children who are younger than 4 or 4.5 years, and pulpless primary teeth in hemophiliacs or patients who have such diseases. Contraindications are teeth with non-restorable crowns. Okay, excessive pathologic root resorption involving more than 1/3 of the root, excessive pathologic loss of bone support, teeth with carious or mechanical perforation of the pulp chamber floor opening into the bifurcation, then radiographically visible internal resorption of the pulp chamber and root canals, presence of any kind of cyst, dentagerous or follicular cyst, young patients with systemic illness like congenital or rheumatic heart disease, chronic kidney disease, hepatitis, leukemia, or children who are on long-term corticosteroid therapy or those who are immunocompromised. Okay, these are the contraindications. Briefly explaining the steps. Steps include administration of LA, okay, rubber dam isolation, and excess cavity preparation, working length determination, cleaning and shaping, then followed by irrigation for the obturation of the canals. Okay, we'll be emphasizing on the materials which are used in obturation. Obturation, the ideal filling material has to be resorbable. Okay, it should resorb at the same rate as the primary tooth or the root of the primary tooth. Okay, it has to be antiseptic, non-inflammatory, non-irritating to the underlying permanent tooth germ, radiopaque, and easily inserted, easily removed if required. Then also it should adhere to the walls of the root canal. It should not discolor the tooth, and it should resorb. It should readily be, resorb readily if it is pressed even beyond the apex of the tooth by mistake, and it should not shrink. So the most important one is zinc oxide eugenol paste, which is used. It was first used in 1876. It's recommended for primary teeth by Sweet in 1930. The powder and liquid composition is written over here. Okay, it has anti-inflammatory and analgesic properties. The disadvantage mainly is of underfilling, because the problem is relatively common, because the mix, once you mix it, usually is a thick mix. Okay, so it's difficult to press it. So underfilling is one of the common disadvantage. Overfilling, if it happens, can cause mild foreign body reaction. The rate of resorption, another disadvantage is the difference in the rate of resorption when compared with that of the primary root. Okay, the root resorption is faster compared to this, so it resorbs at a slower rate. Okay, so particles of ZOE may remain in the alveolar bone for a long time, but it's not certain that it has any clinical effects or not. But yes, deflection of path of eruption of the succedaneous teeth has been reported by a few researchers. It has been found that the retained material can alter the path of eruption of the succedaneous teeth. Okay. Then iodoform based paste are there, like cryo paste, Maisto paste, Guides Pinto paste, Endoflas, Vitapex. Okay, there are a lot of materials which are used now, which has iodoform in it. Iodoform acts by releasing iodine. Okay, the compositions are written over here. May produce yellowish brown discoloration of the tooth. Okay, which may compromise the aesthetics, but that's not an issue because we are going to crown the tooth after performing pulpectomy. Okay, so KRI paste has iodoform, camphor, parachlorophenol, and menthol. Advantages: it has a disinfectant property, superior antimicrobial properties. Due to its smooth and viscous nature, it can be spun inside the root canal using a lenticular spiral, or it can be injected with a pressure syringe also. It is resorbable, so any paste which is inadvertently expressed into the extradental space or the periradicular space can be quickly removed by the macrophages, and it is easier to use than zinc oxide eugenol because it's supplied as a pre-mixed paste, so it's convenient to use. It can be directly placed into the root canal. Then comes calcium hydroxide. Commercially it's available as Metapex and Vitapex. That has the main component calcium hydroxide. Vitapex also has iodoform in it. So calcium hydroxide is considered to have some antimicrobial action. It is easily resorbed when it is pushed beyond the root apex, so we don't have to worry. But the rate of resorption in the canals is also quite faster compared to the rate of physiologic root resorption. So sometimes it causes a hollow tube effect. That is also asked in one of the questions. Okay, alkaline property of the material counteracts the inflammatory process, so it has a very good antimicrobial action. The advantages are it's biocompatible, the antibacterial property, then induction of mineralized tissue formation, also causes calcified tissue formation, activation of alkaline phosphatase and collagen synthesis, ability to produce hydrolysis of bacterial endotoxin. The disadvantages: depletion of the material from the root canals. Okay, so there is faster resorption than the root of primary tooth. This causes a hollow area inside the root canal. This is popularly called as hollow tube effect, which can act as a nidus for bacteria. Okay, usually it's asked in the questions what is hollow tube effect and with which material it is seen. So the answer to that is calcium hydroxide. Okay. Then endoflask. Was recently introduced in, and it's a resorbable paste which is produced in South America. The powder liquid composition is mentioned. Okay. The main difference between endoflask and other paste is that the latter resorbs when extruded extraradicularly but does not wash out intraradicularly. Okay, so even if it is pushed beyond the apex, it will resorb within a week, but inside the root canal it remains. Okay, and it has a similar resorption rate when compared with the primary tooth root. Okay, and it is hydrophilic, so even if the canal is mildly humid, then also we can place it. It firmly adheres to the surface of the root canal, provides a very good seal, and due to its broad spectrum of antibacterial activity, it has the ability to disinfect the dentinal tubules and the accessory canals that cannot be disinfected or cleansed mechanically, okay, by the instrumentation. The eugenol content can cause periapical irritation. Also, it has a drawback of causing tooth discoloration. Okay, endoflask showed marginally better antimicrobial activity compared with ZOE, probably due to incorporation of known bactericidal agents like iodoform. Iodoform acts by liberation of iodine, can irreversibly oxidize and thus inactivate essential metabolic compounds like proteins, nucleotides, and fatty acids, resulting in cell death. Okay, so it is believed that iodine is an oxidizing agent. So with this I have covered almost all the major materials which are being used commonly. Okay, see, the main approach regarding endodontic treatment on deciduous teeth or primary teeth is developed from the clinical and histologic studies. There are research breakthroughs in these fields which are very likely to yield modification in these treatment approaches that would possibly improve the prognosis of all these treatment options. Meanwhile, keeping to the rational fundamentals and case selection operative techniques, pediatric endodontic remains a major benefit to the child's health and well-being. Okay, and the success of the endodontic treatment, it entirely depends on the thorough knowledge and understanding of pulp morphology, root genesis, and the resorptive processes which are happening related to the deciduous teeth. Okay, so this is all about this. If you have any queries, do let me know. Okay, thank you so much.